So it's my privilege to welcome all of you to the 2021 Emile Holman Lectureship, now in its 22nd year. And I got to tell you, that feels good. It's a great annual event for us to reliably and consistently gather, to invite outstanding thinkers and doers, to celebrate our roots in Emile Holman's leadership, and to celebrate the wings of our surgical residents. And just a fantastic set of presentations today, so a quick round of applause for everybody. I'm truly grateful to Drs. Hahn and Morris and Gertner for their continued stewardship of the lecture, and my sincere thanks. Emile Holman was the first of the classically trained surgeons in the scientific world to move west, and for 29 years served as founding executive head of this department. 29 years is a good long time, as Dr. Hahn and I can attest. I think one of the most important things that he did was to establish the tradition of integrated research programs which permeate every aspect of the surgical department, which continues to this day. I think on one of the blurbs, there's a little link to an article that Jack Connolly wrote called The Little Red Schoolhouse back in the city, which commemorated the early surgical research days here. So look it up. We honor Dr. Holman's legacy today. His bio is in the book. It's worth a read. His contributions were legendary, and many of them not as well known as you might think. And I think it's fair to say that past Holman lecturers really a who's who in surgery, and this year is absolutely no different. Famously, Holman's mentor, William Stewart Halstead, said, quote, "The art of surgery is not yet perfect, and advancements unimaginable today are still to come." And I think that basic concept, which was uttered more than 100 years ago, is just as true today, and those advances have come out of the surgical research laboratories and from much of the work that we've heard today, and from, I think, what we'll hear from Dr. Alverdy's presence. So again, welcome everyone. Now I'd like to invite Dr. Kebebew to introduce this year's Holman Lecture. Electron.
Thank you, Tom, and it's a great pleasure for me to introduce Dr. John Alverdy, who's an internationally known surgeon scientist. He's been at the University of Chicago for quite a bit of time. He's the executive vice chair in the Department of Surgery, and also the Sarah Harold Lincoln Thomas Professor of Surgery at University of Chicago. He's been funded by the NIH for multiple years as the Associate Director of the Digestive Disease Center, also at the School of Medicine at the University of Chicago. His really scholarship work is very interesting. He's, as I said, run a continuously funded NIH laboratory that studies the molecular interaction of bacteria and intestinal mucosa in order to understand how life-threatening infections arise after trauma and major surgery. In case you're not hearing me, I apologize, I had my mask on. During critical illness, he's developed several anti-infective polymer-based compounds that can attenuate the virulence of several multi-drug resistant pathogens that cause life-threatening infections in our surgical patients. And he works to synthesize and refine and scale these compounds in preclinical testing. He's also a sought-after clinician. His practice is in complex, minimally invasive, open gastrointestinal surgical procedures in both minimally invasive pancreatic surgery, bariatric surgery. He's developed new procedures that he's been credited for. He's published well over 200 peer-reviewed papers, many in the Nature journals. And he's a member of all the Gust Surgical Associations, and he's received what I call the Surgical Nobel Prize. That's the Flint Carl Scientific Medallion from the American Surgical Association. When I was going to be introducing Dr. Alverdy, I reached out to many colleagues at University of Chicago for some fun facts. He does have interests outside of clinical medicine and research. People said he was a dedicated grandfather, and I was just talking to him, and he said, I have my retirement with my 2 children. He's also a prolific piano player. In fact, his interest in surgery started during his undergraduate studies and really crystallized when he was in medical school. And there's a quote, he said, I think the seminal moment that changed everything for me was when I was working in the laboratory in the middle of my surgery residency doing research. And he said he realized he could get very excited by the idea of creating knowledge. And he said, this is in quotes, your own words, you could go into the laboratory, somebody would pay you to just sit around, think, and do experiments with no expectations that it would actually work, but that you might actually create something in the process. And he gave an analogy similar to playing music. And apparently, him and his colleagues at University of Chicago have a group where he's the piano player, and they're called their turnaround time. They do some philanthropy work and raised funds for overseas trips to the Dominicans to repair cleft lip. But I understand that the group has not been successful in decreasing the turnaround time at the University of Chicago. John, we're delighted to have you as the 22nd Emile F. Holman Lecturer and look forward to your talk.
Thank you, Electron, for that kind introduction. It's a great honor and privilege to be here. I wanted to call the band Shifting Dullness, but nobody really liked that idea. It's a great honor to be here at Stanford University, at Stanford Surgery. This is a premier department. You should all know, those of you that are training here, that you are training in the crown jewel of departments of surgery in the United States and in the world. And the legacy of leadership here with Dr. Krummel and others, and Dr. Holman for sure, and is really outstanding and will reverberate. Certainly has affected my career, Dr. Krummel, reading your manuscripts, which I'm going to give you a shout out at the end here. I want to thank Dr. Hahn for the gracious invitation to come here. The delicious dinner last night, and we were all just sitting around ready to have a kumbaya because it was just so nice to be out rather than being stuck inside. So this is my first slide. I just want to show you some of the people that have done all the work that I'm about to take credit for, and again, thank the Digestive Disease Research Center Corps for their help in this. I've been fortunate enough to be funded for more than 20 years with this grant. And, this is when nobody actually knew what the microbiome was. We called it the gut bacteria. Now it's called the microbiome, and it's sort of everywhere. But we made some fundamental discoveries of how bacteria play a role. And it's not as simple as just getting across the gut and infecting your wounds. It's much more complicated, which I'll go to in a minute. Now, we've been through a painful pandemic, and we're still in it, and there have been some lessons we've learned from COVID-19. The first of which is that despite all of our technology, microbes can still hurt us and even kill us. We know that. Infections affect all aspects of our life, our health, our businesses, our patients, our family, even our elective surgery schedules. Throughout history, we've been in an arms race between us and the sea of microbes around us. Our ability to contain, neutralize, or eliminate pathogens remains fragile. And now we've just seen that play out in real time. I listened to this podcast by this brilliant sociologist from UNC, and she said, COVID-19 is just a dress rehearsal for what is to come, which is a little frightening. Our approach to killing all life that threatens us is not an evolutionarily stable strategy. We know it, But think about it for a minute. Antibiotics are in soil. They started with fungi and bacteria, and they are secreted at little amounts. We've actually taken them, synthesized them, created metric tons of it, and we spread it all over the place. I mean, is that a good thing? Well, it's good that we have antibiotics, but we have to start thinking about it. And after listening to everybody's presentations today, I have to say, and I put this in a long time ago, and I still believe it, the best science emerges from experiments that are solution agnostic. It involves elegant methods and produces results that are unobvious. Think about how, we talked about this last night, how we've rolled out this vaccine. It's just unbelievable that we're injecting mRNA into our bodies and letting our own molecular machinery make an antibody, a protein, with its tertiary structure and all the little spots on it, that's perfect to contain and neutralize this virus. And we can mass produce it, it's scalable. Who thought that would work? 30 years ago, physician scientists at the University of Wisconsin worked on this. I read about them, this Dr. Wolf and his group. Of course, their grants didn't get funded. Their papers got rejected from Science. They were told they're idiots, like everybody else. And that is the history of this. And we're standing here. We're in this area, this beautiful venue, because of these people's work to discover things in a solution-agnostic way. So I'm going to give you a few lessons here. Lesson one is faculty need not be incentivized to do research. They actually should be inspired to do it. And if you're not inspired today, you'll never be inspired. I mean, the work that you are producing here at Stanford is just amazing. And if you want to write a successful R01, and I say the word R01, it's not a K award, it's independent funding. You're an independent thinker, a radical thinker. You have to present compelling preliminary data. You have to generate it. You have to find the money to get it, to generate it. And that provides a clear mechanistic plausibility to your scientific premise. And by the way, your premise has to be transformative to the field. And this is the world you live in today. So I don't know this person, but somebody sent me a TED Talk. Maybe Dr. Hahn knows Marty McCary. He's a laparoscopic surgeon at Johns Hopkins, and he has a TED Talk, and he said the next pandemic is already here, and that pandemic is the pandemic of antibiotic-resistant organisms that are causing infections in the postoperative period. And that observation came from this study, which showed that 50% of the pathogens causing surgical site infections are now resistant to the standard antibiotics that we're using for prophylaxis. How can that be? Now, an SSI can be kind of benign. They're a little red, give them some antibiotics, open the wound, drain it, stick them in the hospital for a few days, put a wound vac on there. But they can actually not be so benign. They're worried about this in Europe. And it begs the question, why do we use a one-size-fits-all antibiotic regimen to prevent SSIs? Why is that? So Adam Sifu, who is an internist at the University of Chicago and a really prominent academic physician, wrote this beautiful editorial in JAMA about from guidelines to order sets to patient harm. You should read this. It's really interesting. It's about, somebody who saw a patient, was about to go to surgery, said, oh, this is a high-risk patient, needs a beta blocker. The patient's blood pressure was like 80/60. But the drop-down menu, give propranolol. Boom, patient got hypotensive. How does that happen? Well, we can't rely on machines only, right? And here's a study by Dr. Hahn and Dr. Itani. And they said the choice of intravenous antibiotics for colorectal surgery does matter. We give the same to everybody at the University of Chicago. And we just had a case where they did a combined right hemicolectomy for cancer, and the patient had contained liver met in the left lobe, so they did a combined operation. The patient got the standard antibiotics, even though the patient was elderly, diabetic, had gotten fulfurinox before surgery because he had metastatic disease. That patient developed E. coli sepsis with an ESBL organism that he was in septic shock, renal failure, the whole thing. and luckily got meropenem at the right time and did well. But is that going to happen more often? What did that patient, what did he have in his microbiome when he came to the hospital? And did we eliminate all the good bacteria and now the bad actors were able to bloom and proliferate? Don't know. So surgical site infections, where do we go from here? Well, our current approach is maintain sterility, give antibiotics. I met a friend of mine in Europe, Eduardo Garcia Granero. He's a preeminent colorectal surgeon in Spain and in Europe. And he said to me, I'd love to do a conference where we talk about where we are, how do we move the needle towards zero? Not let's do this bundle and this, how are we going to get to zero? And you're like, oh, you'll never get to zero. But we have to have a strategy. And our current strategy is this. Let's, change gloves, give more antibiotics, broaden things. That is not an evolutionarily stable strategy, more of the same. So we have to be radical thinkers now, because we're living in a world in which there's an arms race between us, the antibiotics we use, and all the pathogens around us, and we've seen this with the COVID vaccine. So now, mortality from colon surgery, we've come a long way. I'm old enough to remember some of these bad outcomes, but in 1925, the death rate from a colon operation was 30%. And we've come a long way, but actually if you look at our SSI rates and our anastomotic leak rates in the esophagus and the colorectal area, they're still pretty high. We're not sort of winning this game in the sense that, a colorectal anastomotic leak is a disaster. It's disabling, it can be lethal. Patients can end up in the intensive care unit with a colostomy. It's a problem. And I don't think we're addressing it. I want to talk to you a little bit about some of the work that we're doing. I remember this study from Bob Condon, James Clark, Dr. Sherwood Gorbach, who was an infectious disease specialist at Cook County Hospital, and Ron Nichols. And they did this study, and they showed oral antibiotics helped. It reduced septic complications, as many others have now shown this. But they also showed a significant reduction in anastomotic leak rates in the oral antibiotic treated group. Now, there's an old Turkish saying, if you're going to tell the truth, make sure you have one foot in the stirrup, because they knew that would anger everybody. What do you mean, anastomotic leaks? So they wrote in this paper, since anastomotic disruption may be viewed as a technical fault, we analyzed our data with those patients excluded. They didn't want to anger the masses by saying maybe an anastomotic leak is not due to technique. And I can just tell you, I've been in a little bit of a Twitter kerfuffle in the last few days about technique. Technique's very important. And I teach good technique when we do anastomoses. But every surgeon I know who's an outstanding surgeon has experienced this, and it's terrible. There's two victims, the patient and the surgeon. This is Isidore Cohen. He's an iconic figure in American surgery. He did this study in 1955, 2 years after I was born. He had took dogs, did an anastomosis in the transverse colon, put a catheter in there to infuse antibiotics, and he only had tetracycline and penicillin, and he devascularized that. And he showed that not much changed in the flora when you gave the penicillin and infused the tetracycline in there. But if you look at these actually, you can get these photos right out of the Annals of Surgery article. None of us would close an abdomen with a colon that looked like that. But when you gave the group tetracycline delivered right to the site of the anastomosis, not only did it reverse the ischemia, but it prevented leak in those animals. And I don't have to show you what happened in the group that got saline. So does this prove that microbes cause leak? Can intestinal ischemia be reversed with antibiotics? Now, if you talk to a vascular surgeon who has an ischemic colon after an aortic operation, they'll say yes. Talk to a pediatric surgeon who's opened the abdomen up and everything's dead in a neonate, and they close it. They give antibiotics, and a lot of it comes back. What's up with that? We should know at the molecular level how that works. Here's a study from 1975 by Harry Levine. They took dogs, did an anastomosis in the transverse colon, and then gave the dogs antibiotics for a day, oral antibiotics, and they used erythromycin and kanamycin. I had a discussion this morning with Dr. Kin. We're like, why do we give Flagyl? It used to be neomycin and erythromycin. How do we switch to Flagyl? Well, patients hate erythromycin. And so was that the right choice? I don't know. So here's this dose. One day, above controls, you have a 20% increase in the tensile strength of that anastomosis. If you do it for 3 days, you have a 50% increase in the tensile strength of that anastomosis. And if you do it for 6 days, you have a 70% increase. How is that working? There's no real molecular mechanisms here because cultures were bad back then. They didn't have the tools that we have now, as we saw this morning and today. We have molecular tools that are just outstanding. We need to know why that is. But there's not much to conclude between these two studies, 1955 and 1975, other than the fact that bacteria seem to play a key role in anastomotic healing. Now, when there's a plane crash or an unexpected event after a plane crash, after any kind of air flight, think about how there's a root cause analysis of that problem. You know, you get the NTSA involved, you get the FFA involved, the plane is reassembled in a hangar, there's an inspection, there's a 3-month deliberative period where they, by consensus, go through the black box and everything else and figure out, and then a report is generated. It takes months. Think about M&M. I call it a place where we learn from the ignorance of experts. Yeah, well, I hate that stapler. That stapler's no good. Why didn't you hand sew it? Was it ischemic? Oh yeah, it was blue, we closed. You know, what are you talking about? It's the same comments. I've been all over the place. It's the same comments every time. And then, next case, what do our students and residents leave thinking when there's an anastomotic leak or a surgical site infection? So, you know, that needs to be resolved. Today, there is no evidence to support the claim for any anastomotic leak that it's due to an error in surgical technique. At our hospital, it's booked that way. What was the cause? Error in surgical technique. Okay, what was the error? You don't know. You know, most cases are treated non-operatively. You put a percutaneous drain in. You can't expect that anastomosis. Technique is important. You need to pay attention to technique. I'm not saying technique is not important. I'm just saying that the evidence in an individual case that it was due to technique does not exist. And they're few and far between, thank goodness. And the same could be said for surgical site infections. Under current practices, you wait 3 minutes, you do your timeout, your debrief at the end, everything, change gloves in the middle. There's no evidence to support the notion that somehow something happened that was due to an intraoperative contamination event. So this notion of getting to zero may require recognizing two reasoning errors. What I'm going to talk about in a minute, which is this between-group comparison fallacy, which I'll point out, and our tendency towards solipsism, which I learned that word from Ben Eisman, who gave a talk once, and he said, we're too solipsistic. And I'm like, well, I don't know, what the hell does that mean? And it means that the self is all-knowing, that all knowledge that we have is from our experience, and that represents an objective view of reality, which it doesn't. So here's the between-group comparison fallacy. We have patients with risk factors for an anastomotic leak. Their male, gender, obesity, blood loss took a long time to do the case. And we have a p-value showing that those without the risk factors have less leaks. I just made these number up, 20% versus 10%. Here's what we don't do. Same risk factors, but no leaks. Why? Well, if it's in my case, the reason those patients leaked, patient-related factors. Why didn't they leak? Because I'm a good surgeon. I use the EEA and I don't squeeze it too tight and I reinforce that. We have no idea. Same on the other side, right? No risk factors, but there's still leaks. Why? Well, yeah, patient was overweight. That was a hard case. You know, we make it up on the fly. We need to know the answer. And so we must account for within-group differences in our studies to avoid the between-group comparison fallacy. You know, that's why I put it here, have p-value, will publish. It's not enough to know this. And that's why when you think about this, from guidelines to order sets to patient harm, we have to figure this out or we're going to keep doing the same. So there's a reason to understand the factors that increase the probability of leak And there they are, smoking, radiation, obesity, et cetera, and factors that cause a leak, those that are deterministic. And I think this involves the microbiome because all of these risk factors converge on the microbiome. But it's not enough. There are multiple contingencies and steps that have to occur first that we've discovered, at least in our mouse models. First, the microbiome has to collapse in structure. Well, we do that very nicely by starving our patients overnight, giving them antibiotics, bowel prep, et cetera. And remember, the normal microbiome, they're your friends with benefits. We're learning now that they secrete metabolites that are critical to drive the immune system toward a recovery-directed phase. They are also the firewall that keep pathogens in check. So what are we doing right and what are we doing wrong at the individual patient level? We haven't developed enough molecular tools to understand that. And then there's this cascading effect where you collapse the microbiome to a certain degree, then you have a predominance of these collagen-lytic microbes. It's still not enough. You have to have what I call in vivo virulence activation. I'll show you that in a minute. The bugs have to adhere to the tissues. They have to develop an immune escape mechanism. They have to activate tissue proteases. So you get this supraphysiologic activation of tissue proteases, and then you have a leak. So a lot has to happen first. It's not just the presence of bacteria. A lot has to happen beforehand. And so how do we preserve their function yet contain their virulence? Killing all life that threatens us cannot possibly be an evolutionarily stable strategy. And I show this study from the British Medical Journal, 1899. There's no DNA, there are no antibiotics. I don't know how these people knew this. They had a discussion on intestinal antiseptics. A friend of mine from London sent this to me. And it says, Mr. Treves, referring to this organism, it was E. coli, observes, it would appear to be harmless when taken from the normal intestine. If, however, the bowels become the seat of almost any morbid condition or change, the bacillus becomes virulent at once. What did they mean? Well, it turns out, and this is what I've been studying for 20 years. When I studied this 20 years ago, people looked at me like I had two heads. But virulence is conditionally expressed and it's context dependent. And so postoperative GI complications occur when local bacteria at wound sites become in vivo activated in response to host cues. We heard this word a lot this morning. Cues, environmental cues, local cues in the wound. What are they? Well, we've identified a number of them, cytokines, opioids, ischemic end products. And while the whole world was sort of looking at how microbes activate immune cells through different receptors like TLR4s and others, I looked at things in the exact opposite direction. And I asked, how are bacteria responding to tissues that are traumatized or injured or inflamed? And we discovered a number of different molecules that are locally secreted that can turn bacteria on. And in turn, those bacteria secrete toxins and products and PAMPs that turn on the bacteria. And there's this sort of inter-kingdom signal exchange that goes on, this sort of iterative learning loop. And then bacteria have their own way of communicating through a system of quorum sensing. And so there's interspecies and intraspecies signal exchange. And now you have this molecular hairball. It's a highly networked, and I call it a matchless web of dense dynamic interactions that are unique to the environmental context. Well, that's hard. One of the microbiologists I worked at U of C said to me, there are no units, there are only interactive systems. Stop thinking about units. Oh, let's block this or let's block that. We have to block the system interaction that's being cued by the environmental context. Not so easy. So virulence, this is a friend of mine, Arturo Costa-Deval, who is a infectious disease specialist at Hopkins, who's been very vocal during the pandemic. He said virulence is neither a property of the pathogen nor that of the host, but rather it is a property of their interaction. And that may be why we can't sort of figure out why one person gets COVID and they're sort of asymptomatic and the other person gets it and they die. I actually had a close friend who's a vascular surgeon who Jordan Stern there knows, Dr. Piano, who got sick and 3 weeks later died of COVID. And he was 62 and asymptomatic on no meds. How do you put that together? He had the mask on, he protected himself. We don't know. So when you think about it in this context, it's a little difficult to disentangle. So here's 20 years of work from my lab. We took animals and, operate on them, cause ischemia reperfusion injury, did this in cells, this is in animals, and isolated loops of bowel, and we discovered soluble factors that bind to the bacteria, activate these bacteria to express a higher degree of virulence, and then looked at what happened to the bacterial host engagement. And the good news is that you have this recursive molecular dialogue that filters noise and signal, and most of the time, it ends up in molecular detente. It's a trust but verify system. It's in the host's best interest to know the status of the bugs, and it's in the bug's best interest that live off of us to know how the host is. And both of us need to leave each other alone most of the time, which is why we can do these operations, these 6-hour operations. You're like, oh my God, and the patients do great most of the time, but not always, right? So virulence expression is rare. It can be stochastic, and it's often unpredictable. So, one lesson is you never know when you start out. I started out studying bacteria, at a very sort of basic molecular level, and I ended up studying an anastomotic leak and becoming, for some reason, the world's expert at the most dreaded, horrible complication ever. And it was because of this woman here, Andrea Olivas, who came to my laboratory. She wanted to go into colorectal surgery. She said, I want to study something about the anastomosis in the microbiome. And I said, well, I have an idea. Let's ask the question if bacteria shift their virulence in vivo and actually cause the anastomotic leak. We have to prove causality, determinism between the bacteria, its state of virulence. And this paper was really one of the best papers I've written. She did all the work here to model this perfectly, where she did preoperative radiation of the pelvis, then did the low colorectal anastomosis in rats, then put Pseudomonas in the cecum so it would move around, and then looked at it, both by sequencing and both by phenotype, and showed that the bug in the environment of the radiation field and the anastomotic wound shifts both its genotype and its phenotype so that it produced a bunch of collagenase and turned into a flesh eater. In the control animals, no leak. The Pseudomonas didn't transform. In the animals that got radiated and were operated on, the Pseudomonads transformed. And we studied that at the very molecular level. And then Ben Shogan came and followed, and he wanted to do it without introducing a pathogen, and he was interested in Ephekalis, and he basically showed the same thing. And this is probably the most molecular detail you'll see out of any study done on an anastomotic leak, where he showed basically what the paradigm in the lab is, that soluble factors are released by the host that activate Ephekalis, which can be a commensal or a pathogen. It's Dr. Jekyll and Mr. Hyde, and then it activates certain, it not only makes its own collagenase, but activates certain proteases that get turned on and disorder normal healing. And Ephekalis is interesting because it does regulate its virulence through quorum sensing and it's very interesting that, brilliant minds in this field like Tom Hunt and others had this idea that collagenase might play a role in an anastomotic leak, but they were looking at tissue collagenase, not bacterial collagenase. And bacteria make 1,000 times more collagenase or protease than host tissues. And remember, when you remodel your collagen that makes all your wounds strong, it's a question of synthesis and breakdown. Synthesis to get those disulfide bridges and the strong collagen you want to hold things together. But if you over-amplify breakdown, you're going to have a problem. And they only looked at it in the tissues. Had they looked at it in the bacteria, they would have seen something different. So Ben did this study, and he devascularized he cut the blood supply in rats and did an anastomosis. Now, when you look at this, you're like, Alverdy, are you daft? It's ischemia. Look, it's right there in front of your face, right? Except if I ask you, okay, then why didn't these rats leak? And this is, where there's a lot of hand-waving use of metaphors, blaming of anesthesia, I don't know. You say, well, they were less ischemic than the ones that leaked. No, they weren't. We looked up and down for that. We just cut the blood vessels, but the bowel looked grossly normal. We did endoscopy. We even did confocal laser endomicroscopy, injected a fluorophore. We injected hypoxia probe. We did CD31 imaging. We could not detect. In fact, at 5 days, there are more blood vessels there in the devascularized group, probably because you're turning on HIF-1 alpha, VEGF, and everything else. You get more blood vessel growth. So this notion of ischemia, I mean, I'm not saying it can't be operative. It has not been proven to be the cause of an anastomotic leak, but that's what we say all the time. So what he did is he looked for these collagenolithic pathogens on the anastomosis, and he could show that within group, this is not between group, within the group that leaked, those that had a lot of collagenolithic Ephekalis leaked, and those that didn't did not leak. And that mapped to the amount of collagen within the group that was treated with the devascularization procedure. And so bacterial collagenase, not ischemia, discriminates between those that leak versus those that heal within the group that leaked. So reconciling within group differences with molecular level science is the way to go. I know this paper was sort of highlighted a lot, but this is Dr. Longacre's recent science paper. This is transformative to the field. It has unobvious results and elegant methods, and that's what it's going to take for us to understand the problems that have eluded us for all these years. It can't just be anastomotic leaks. Alverdy says it's bacteria. Well, let's throw in a few more of them. What do you got there? Meropenem, cephalo du jour. What is it? It's got to be something more. We have to understand this better. So I know some of you are thinking, listen, Alverdy, I operate on people, not rodents, so this has nothing to do with my patients. But keep in mind that 100% of mice have Ephekalis on their anastomotic tissues, but the mice that don't leak, the ones in the control group, and medical students and residents do these operations in mice, and if you just do nothing to the mouse, they all heal. But interrupted 5, 6, 7 sutures, got 100% healing. Kind of like the first time I saw when I rotated in pediatric surgery, it has a single layer anastomosis with some vicryl. I go, look, you can't do that. Healed perfectly, right? But if they have Ephekalis there, because we do things, we provoke the system, the mice leak, the rats leak. But the leaks are mostly subclinical. Now you look at that panel on the left and you'll see that in that horizontal arrow. That anastomosis has a piece of omentum on it. If you pull it off, there's a hole. Same with the one on the right. It's a partial small bowel obstruction. Small bowel is covering the hole. Pull that small bowel off, there's a hole there. Now that mouse looks fine. And you're like, I don't want to know about that patient on Friday at 5 o'clock in the afternoon. Get a CAT scan. If there's no leak, stick an NG tube down, leave me alone. Okay? Only 5% of these, 10% of these animals developed either abscess or peritonitis, only 5 with symptoms. We do not differentiate between anastomotic dehiscence or anastomotic leak. These are the known unknowns. And we need to know these unknowns. We need to discover this, and I'm going to show you how we can do this. So getting to zero is what we need to think about. Your generation needs to think about it. Most approaches to reduce SSIs are based on the assumption, right, that it's some type of intraoperative contamination event. And we've used these approaches that seem to make sense. Well, let's put some chlorhexidine gluconate in the wound, spray it in there. If you've seen this product, it's got a nozzle on it, you spray it in the wound. Wound protectors, I use them, I think they're good, but actually a recent prospective randomized trial showed that it did not prevent wound infections. I have a theory about why it prevents wound infections. It's not just protecting the wound, it's sort of less trauma and ischemia on the wound over the case, and that may release less soluble factors for the bacteria in there. And these approaches seem to make sense also. And none of these have worked. I mean, this was published in the British Journal of British Journal of Surgery. And sticking this Cologuard or condom up there and stapling it caused more leaks than less. And the company raised like $5 million to do this study. this is, it's not mechanical. It could be mechanical, but it's probably mostly biologic. So Neil Hyman and I and Jack Gilbert, who's a microbiome scientist that I work with, he's now at UCSD, we wrote this paper because we wanted to ask the question, when you get an SSI, do the bugs that are in there match the ones that were present when you closed? And it turns out that they don't. And we reviewed every paper, and there were a number of them. Wound cultures from the operative field do not correlate with the pathogens cultured from an SSI. So where do they come from if that's not the case? That makes no sense to us, right? If you swabbed every wound before you closed, what you found in there when you closed would be what would cause the SSI, not the case. Now, somebody needs to explain this to me, because we put this in the paper. Got a lot of grief about this. How is it you can make a colostomy and not get a raging cellulitis and a deep muscle wall infection? You are suturing the mucosa up to the skin. Then you stick that bar in there, and here's the piece de resistance. You take that bag, and you create the greenhouse effect. Let the humidity come up. Let the sun shine. Let the flowers grow. No infection ever. Anyone have an explanation? I don't. Dr. Hyman doesn't. Nobody I know can come up with an explanation. So when you say it's from bacterial contamination, change your gloves. Keep in mind that you can do this, and most of the time you don't get an infection. So the scientific lexicon is necessary and sufficient. Bacteria are necessary. You can't get a wound infection without bacteria. But alone, they are not sufficient to cause an SSI. So Dr. Kraselek, Monica Kraselek, she spent 2 years in my lab, and we came up with this hypothesis, and she did a really marvelous job of showing it in animals. And that's why I got up at the microphone today and say the question you ask and the experimental model that you develop is probably the most critical part of how you formulate a hypothesis and generate really great knowledge in the field that's relevant and transformative to the field. We have all these molecular tools now. You can outsource them. That question is really important. And she did a wonderful job at doing this. And our hypothesis was that certain bacteria, let's say those that are colonizing a crypt in your cecum or in your transverse colon or your small bowel somewhere, that they can be taken up by a neutrophil, and that neutrophil can silently travel in the bloodstream carrying an infectious payload. So this is this idea of molecular detente. Neutrophils should eat up the pathogen, or the pathogen should kill the neutrophil, but they're coexisting. And then it gets to your operative site because your operative site is a chemoattractant for neutrophils and macrophages, and then it dumps its infectious payload. And here's how she did this study. And she did a fantastic job. And it's been repeated by a number of investigators who came to the same conclusion. She gave antibiotics, starved the animals overnight, gavaged down GFP-labeled MRSA, then did a sterile operation, prepped, draped, the whole thing, did a 30% hepatectomy in the mice, then created a wound with a little trauma. You kind of beat up the muscle a little bit, threw some suture on there, then followed the animals. She showed that the GFP was very able to be detected by fluorescence. She had to gate a lot of mouse blood in a lot of mice to actually see the GFP labeled MRSA inside of a neutrophil and then culture it. And we got what were called small colony variants. It wasn't easy to culture those. Those bugs start to hibernate. They turn down all their virulence tactics because they want to live inside that neutrophil, but we're able to culture them. We had to show that they remained in the gut and that those that were in the gut were the ones that ended up in the wound. And then as a control group, I had her take MRSA, do the incision in these animals, do the same thing, and then paint every day the wound with MRSA. None of those mice got infected. You'd say, well, MRSA, that comes from the skin. That comes from the outside, that goes in. The staples, the clips, they came from the outside and went in. You can't make a mouse develop an MRSA infection by painting the outside of the wound every day for 3 days with MRSA. But only 10% of the mice, even though many of them had culture-positive MRSA, the wound did not look infected, only 10%. That's like the anastomotic leak model. So the question you pose is likely to be the most important aspect of your research career. Experimental design is critical, and a hypothesis is not to be believed, it is to be tested. I stole this from this book by Elizabeth Blackburn, who discovered telomerase. If you read her biography, which I read, I saw it in the bookstore, I grabbed it, I read it. You know, of course, her grants got rejected. Her postdoctoral advisor said, telomeres at the end of DNA, what do you study? Nobody cares about that crap at the end of the chromosome. Nobel Prize, okay? She generated killer preliminary data that provided mechanistic plausibility to a premise transformative to the field. So how are we going to manipulate gut microbes to our advantage? Because I think that's the next big thing. And everybody else thinks it's the next big thing. And you're probably sick of hearing about the microbiome because you just it's hard to understand it because it's a complex web of dense dynamic interactions. It's not one bug. You know, so either you're going to give patients a fecal transplant, which we're doing for C. diff. You're going to give them a crapsule. Okay, now they're about, you got a lot of these companies in Silicon Valley here. They're raising tens of millions of dollars to develop this crapsule that you'll take, you'll grow hair, you'll live forever. They want it as maintenance of health. They don't want to treat a disease. They want you to take this pill every day like a vitamin so they can make a lot of money. And it's going to be a hard thing to deliver because what you put in a crapsule doesn't stay there. And your own microbiota have home field advantage. It's very hard to clean them out. And we think the best way is a high-fiber, low-fat, plant-based diet. Now, I'm preaching to the converted here. You know, in California, you guys probably eat, I know Dr. Krummel probably eats a kale smoothie every morning. Is that correct? No, I don't know. I made that up, Dr. Krummel. Okay. So back to basics, right? So here's our idea. This is nature-inspired design, right? When microbes, we showed this in several papers because we played around with the conditions of the in vitro when we grew different bacterial strains. We put in the host factors that activate their virulence, but when we raise bacteria in a nutrient-rich environment, they become insensate to any of those signals. They will not express virulence. They're like, look, I got plenty of food here. Why would I waste the ATP making virulence factors? I can eat and grow and reproduce. And that's called fitness. A fitness advantage is the ability of bacteria to reproduce. And so if you could embed the gut with public goods, you could actually provide unprocessed foods to this biologic marketplace and let the microbiota decide how to metabolize and share it, which they do right now, which is why none of us are sick. And maybe people are showing this with COVID, it makes a difference, right? If you eat well, and it's not a function of your weight only, it's a function of what you eat that will nourish your microbiome to protect you against invading pathogens. Now, industry wants to sell you this stuff. They believe in better living through chemistry. They want to sell you a chemically defined, sterile, liquid diet to give your patients, and they don't want you to give them one bottle pre-op. This is immunonutrition. They want 2 to 3 a day for 7 days. You know, buy a case. Have your patient eat. Your patient shouldn't be eating this. Your patient should be eating, I don't know, unprocessed plant food. So what happens if you feed mice a Western diet, which we did? It's called a PUFA diet, polyunsaturated fatty acid diet. Give them some antibiotics, NPO after midnight, and do an operation. Their collagen-lytic microbes increase by 3 orders of magnitude on the anastomotic tissues. It's a 1,000-fold increase. All I did here was give them a Western diet. Now, if you're doing animal models and you give mice their normal diet of chow, chow is way too healthy. Our patients don't eat chow. You ever look at chow? It's plant-based, high fiber, low fat. Nobody eats chow. I wish I ate chow. I'd probably be healthier than I'd probably have hair, okay? You know, but that's not what our patients eat when they come to us, when we operate on them. And yet we don't model our diseases with the same diet that our patients eating. Well, if you do that, all your anaerobes go away. Not only did the collagen-lytic microbes on the anastomosis go up, but we're about to publish this. just giving them a Western diet, you start to see E. coli that is ESBL and Enterobacteriaceae, which is AMP-C positive. This is extended spectrum beta-lactamase positive E. coli and AMP-C positive Enterobacteriaceae. I mean, these are ones you need meropenem to get rid of. So you kill all the good guys, and you let these things bloom because of the diet alone. And we were able to increase the leak, the actual clinical leak rate, the ones that you would say, that's a leak, an abscess or peritonitis, by 50% just giving them a Western diet. It's 10% if they eat chow. So I showed these data to Professor Harry Flint, who visited the University of Chicago. He's from Scotland. He's the world's expert on human nutrition and the microbiome. And he said to me, I'll bet you 2 days in those mice of just switching them back to chow. They're on 6 weeks of a PUFA diet. 2 days, that's all it'll take. I'm like, no, that's not gonna work. And he was right, it worked. 2 days, we're able to shift their microbiome from 6 weeks of PUFA back to normal. Now, here's the study that we had to do to prove that it was gonna make a difference in an anastomotic leak. 2 days beforehand. Now, 6 weeks of PUFA is a long time for an animal. These animals get fat, their hemoglobin A1Cs go up, they become hyperglycemic, their livers get fatty, they have a lot of visceral fat. You're like, you're not changing that with 2 days of chow. This animal's fate is sealed by 6 weeks of getting fat and getting hyperglycemic. Not the case. We were able to reduce leak rates clinical leak rates by 66% with 2 days. So imagine if you took your patients and gave them a week of a, not bacon and eggs in the morning and a hamburger and fries at lunch and, I don't know, meatloaf, gravy, and, mashed potatoes for dinner. And so Bobby Keski, who's getting his PhD in my lab, did this very nice paper published in Annals recently, and he defined microbiome readiness for surgery. It's not just about looking at who's there. It's about looking at who's there and what they're doing. And it turns out that he created a ratio between the amount of butyrate that's produced, which is a surrogate marker for the number of anaerobes that are recovering. And it's not just, we're going to knock down the bugs when we give them antibiotics in our bowel prep, but there's certain patients that recover quickly and those that don't. And we need to know who they are that recover and why do they recover quickly. And we need to track that. So only two more slides. So when we think about how we get to zero for our patients with both anastomotic leak and SSIs, we should think of how we're going to target the microbiome. And in my opinion, and I hope this study gets done in humans, Dr. Kin and I discussed this morning, is imagine if you put patients on a plant-based, high-fiber, low-fat diet for 3 days, and then you determined microbiome readiness for surgery. Okay, not what's their prealbumin level, what's their microbiome readiness. You screened for these collagen-lytic bacteria. Now, I've given lectures to infectious disease specialists, and I've been in a room with 1,000 people. I go, raise your hand if you've never taken antibiotics. Nobody raises their hand. Raise your hand if you haven't taken antibiotics in the last year. Like a third of the room raises their hand. I'm like, we take antibiotics, we take too many antibiotics, not to mention the fact that 80% of the antibiotics sold today are sold for animal feed. That's scary. I didn't talk to you about this, but we have figured it out what these microbes really want, and they want phosphate and other minerals to suppress their virulence in response to host cues. And we've developed a number of these compounds, as Electron was talking about, that it's a sort of an eco-neutral, non-antibiotic approach. And then this is Dr. Christina Guyton, who worked in my laboratory for 2 years. She's a colorectal surgeon now. She did this really nice paper with Neil Hyman showing that that you can serially endoscope patients, and you can look at their anastomosis intra-op before they go home and 2 weeks later, and you can wash that anastomosis and you can get a lot of information out of it. And they accept it. In fact, we did 10 patients, and most of the patients, when we looked at like two weeks, they were like, thank you, doctor, it's okay. I'm relieved that my anastomosis looks good, because for those of you that do colorectal surgery, Dr. Boris and others, you know that the discussion you have with the patient beforehand is kind of ugly. Well, you could leak even though I do a good job, and you could end up with a colostomy, and you could end up in the ICU. And so it's actually reassuring to them. And we need to do this so that we can understand this at its root cause level. Here's that same paper from 1899. I don't know how these guys knew this, these people. I don't know how they knew this. They write, "We are still very much in the dark as to the precise mode of action of pathogenic microbes, but we do know that their activities and their virulence vary greatly according to their environment, and that it is not necessary to kill them in order to make them relatively harmless." Where did they come up with this? Because it's so prescient. And maybe that's the most evolutionarily stable strategy. Food is medicine. So this is the last slide. Lesson 3, the elements of a successful career in research. Knowledge, you need knowledge. You're in the best place to get that, but you don't need too much. Read this book. Watch this TED Talk by E.O. Wilson. He's an evolutionary biologist at Harvard, studied ants. It's just brilliant and inspiring. I don't think curiosity and passion are enough. I think you need obsession. Now, when I was a resident, I watched a mother with her 10-year-old child hooked to a ventilator, the tubing, rock that child to its death. The child had leukemia a year ago, got induction chemotherapy, was doing great, had a Hickman line, and I was on the pediatric surgery service with Dennis Schermetta. Do you remember him? Dennis Schermetta. And we pulled the line out, took the kid, explored him, ID, everything, and that mother's face every day when I walked in the room rocking that kid. And once you see that face, it can't be unseen. And that kid died of sepsis, and all the king's horses and all the king's men couldn't save that child. And, it's obsession. It's not curiosity and passion, for me anyway, I don't think. And there's risk. What's the risk of becoming a surgeon scientist? Well, you're not going to, you can't just be seduced by the operating room and operate all day long. And your mentors and your leaders here are proof of that, it takes more. You're at Stanford University learning how to become a critical, radical thinker and an operative surgeon. And so I shamelessly stole this line, "Surgery is not an operation, but an intellectual discipline," from this paper that Dr. Krummel wrote. What is surgery? If you haven't read this paper, you need to read this paper because it is nothing short of brilliant. It outlines what it takes to be a radical thinker and transform the field of surgery. And you're in no better of a place to do that. And you are all 1,000 times more talented and smarter than I am, and you should do it because it's important that you do it. And I will end there and thank Dr. Hahn for the gracious invitation, and thank you all for your attention and the privilege of this podium. Thank you.
That was terrific, invigorating, and we have a couple of questions. I think we have time for a couple of questions. This is Slido. Given there aren't strong data to support ischemia for colon leak, should we not perform intraop SPY?
Yeah. I don't have a problem with SPY. I think the data are weak. I think you do everything, we live in a world of augmented reality, so if it helps you, and if it's going to help one patient because you're going to identify a corner that looks ischemic or looks blue that you can't see with your eye, then you should use it. I don't think it's been widely adapted and accepted by colorectal surgeons in general, or even esophageal surgeons who do a lot of pull-up because they don't believe that the data is strong enough. And again, it suffers from the between group comparison fallacy. I actually just wrote a paper on this because you'll see I had a 20% leak rate and I used iSpy. Now I have a 10% leak rate. And then you look at the paper and you're like, well, if iSpy works, why do you have 10% leak in the treatment group? And then you look at the pictures, and the anastomoses themselves don't light up with green. Now you say, well, as long as it's good in front and behind it, the anastomosis doesn't count because the blood supply. Is that true? I don't know if that's true. So I'm not a fan of it. The colorectal surgeons I work with don't use it. I have no problem using it. Maybe it will show someday to be useful. That's my answer.
Yes, and for M&M, we'll have to remember it's not a technical issue, right?
Yeah.
For those anastomosis.
Well, you know, when you're anastomosis...
Sherry, did you hear
it's-
that? We have two more questions.
Yes.
Dr. Melcher asks, we often place our malnourished pre-op patients on tube feeds before liver transplant. Should we be using kale smoothies as the tube feeding for these patients?
The reason, actually, I'm just have a paper pending in Nature Reviews Gastroenterology that I wrote with Victoria Gershuni, who is a fifth-year resident at Penn, and she's going into MIS surgery, so you may see her around soon. She's terrific. She spent 2 years in the lab at Penn in the nutritional science lab, and she wrote a paper about why is it that we use chemically defined diets in these circumstances. And we looked at the history of it, and chemically defined diets started at NASA when they couldn't figure out how to get somebody to poop in space. And they had them drink Vivanex, which is what came out, because you don't poop when you're drinking a fully elemental chemically defined diet. Now, is that right? In the era of microbiome sciences. And so we just kind of articulated this idea. My opinion, with no data, and a hypothesis is not to be believed, it is to be tested. Thank you, Dr. Blackburn. So it is a hypothesis yet to be tested, and you'll have to randomize your patients to tube feeds versus tube feeds with some fiber and see if the outcome's different. Do you remember it still exists, and Nestle has a product called Complete B Modified. Do you remember that? So Complete B Modified is blenderized food. It's like meat, potatoes, peas, carrots, blenderized, and it goes in tube feeds. The nurses in the ICU when I was training hated Complete B Modified. I'm like, why do you hate that? The patient poops every day and it stinks. You give them the Vivanex, no bowel movement. Is that good? I don't know. Anyway.
All right. So it sounds like a randomized trial on the transplant service. Last question here. Intermittent fasting has significant health benefits. Do you think it has a role to play alongside instead of plant diet for preoperative optimization? Intermittent fasting.
Yeah. I don't know. Honestly, I don't know, but I think these, again, we need to think of what we're doing today and what we can do better and how we're going to measure what is better. What is better has always been outcome, but if your leak rate's 7%, you need I've already done the power calculations. You need 400 or 500 patients in each arm to look to see if leak went from 7% to 3.5. It's too hard, you know, or a liver transplant. I'm going to switch from, you know, I don't know, Ensure to kale smoothies. Well, you got to do 400 liver transplants to see if the outcome's different in each arm. So it's not possible. So we have to come up with other measures, and I think it's going to be microbiome readiness and metabolomics in the blood.
Great. Thank you very much, Dr. Alverdy.